Thanks for this opportunity, Dr. Vijay Kumar sir and Dr. T.A. Khan. This is our team at Apollo Hospital, Secunderabad. So this is more of theoretical. I am going to discuss about list of complications and their clinical presentation post gastrectomy. So it is a constellation of complications secondary to the anatomical and physiological changes which may follow the gastric surgery. There are so many list of complications, like general complications like any pulmonary complication like atelectasis, pneumonia or respiratory failure, deep vein thrombosis, wound infection, all these comes under general complications. Or acute complications like anastomotic leak or duodenal stump blowout and acute pancreatitis, although very rare. And gastric reservoir dysfunction like metabolic dumping syndrome and metabolic alterations. And because of denervation, there can be gastroparesis, vagal denervation, diarrhea and gallstones. And because of aberrations in the reconstructions, which may cause afferent loop syndrome, efferent loop syndrome, jejunogastric intussusception, Raustasis syndrome, and bile reflux gastritis. And it can be long-term complications like nutrients, micronutrients, and macronutrient deficiencies with recurrent ulcerations and stump malignancies. So anastomotic leak incidence is around 9 to 12%, and with laparoscopy it is decreased, but still it is there around 6%. Usual presentation will be on day 7 to day 10. So most common risk factors are old age, long duration of operation, and increased blood loss. And as we all know, it can be 3 types. One can be microperforation, one can be there is only radiological, or 3 is both clinical and radiological presentations. So it can be early or late. Early most commonly due to technical failures, whether it can be misfiring of staplers or undersizing or bunching of the tissues when we are firing the staplers. So usually there will be sudden onset of abdominal pain with fever and tachycardia. And late gastric leaks are usual around post-operative day 5 and day 7, most commonly due to tissue ischemias. And the most feared and morbid complication is the duodenal stump blowout. So usually it will present between day 5 to day 10. And why it is called blowout? Because there will be sudden onset of symptoms and there will be sudden extensive intraperitoneal contamination. So this is also similar to anastomotic leak, where you will use undersized stapler or misfired, whether you are overshoot the stapler or not. If there is any distal obstruction at JJ site anastomosis, difficult to duodenum, any previous peptic ulcer or all this cicatrized duodenum, or extensive mobilization was done, or extensive tight closure was done. All these are the risk factors for the duodenal stump blowout. Acute pancreatitis incidence is very rare. Usually it, more with the extent of the lymphadenectomy and magnitude of gastrectomy will correlate with the incidence of acute pancreatitis, usually due to injury to the pancreatic parenchyma or disruption of the pancreatic microcirculation, or sometimes spasm of the sphincter of Oddi, which results in the acute pancreatitis. Coming to dumping syndrome, it can be early dumping syndrome and late dumping syndrome. If there is any rapid delivery, because we have there is a gastric capacity is decreased and we have done gastrojejunostomy, so there is a rapid delivery of the nutrients into the duodenum. So because of that, there will be a hyperosmolar contents into the small bowel, resulting in the release of incretins and glucose modulators, resulting in the early dumping syndrome, which includes vasomotor symptoms and gastrointestinal symptoms. And because of rapid absorption of glucose in the small intestine, which results in a hyperinsulinic response, resulting in hypoglycemia, causing neuroglycopenic symptoms. So these are the difference between the early dumping syndrome and late dumping syndrome. Usually both will be precipitated by taking carbohydrate-rich food, but it will be early dumping syndrome will be relieved by lying down, and late dumping syndrome, because it's hypoglycemia, taking food will relieve the symptoms. And early dumping will be aggravated by more food because osmolality will be increased, and the late dumping will be increased by exercise. Already hypoglycemia is there, it will be aggravated. So there is a scoring system for dumping syndrome, which is a 6-star scoring system. If the score is more than 7, it is more of a dumping syndrome. If it is less than 4, we have to rule out other causes.